In order to answer David's question, I'm going to need to take you through the Grantham site's experience of Abeya. Now, this is about joining up the top level of the organisation with the actual work that happens at ground level. So what our challenge was now really was to understand how to utilise the Abeya effectively to do that. How were we going to utilise it to join up the high-level requirements for a length of stay reduction to what actually happens at ward level? Well, with the rest of our journey, we just had to have a go at it. We decided that we should have a meeting in the big room, in our Abeya room, and we thought very carefully about the people that we wanted to involve in that meeting. We decided that they should be people that could affect change, influence behaviour, and also those people that understood what was happening on the wards at ground level. So we settled on the hospital manager, our operations manager, some matrons, and our ward managers, believing that these were the right people to have in the room. We settled on a weekly meeting, but even this was difficult because getting this group of people into a room together all at the same time, even once a week, was a very big challenge for us. We then thought we ought to decide on a purpose for the meeting because all good meetings should have a purpose. We decided that we would utilise the Abeya to review the data, understand hospital performance, that we would check and adjust our plans, understand our progress against them, and then try and understand any difficulties that the wards were having in implementing those plans. It was difficult to get this meeting right, and we took several PDCA cycles before we were happy with the structure and format of the meeting. But we did learn a lot, and I'd like to share some of that learning with you now. We learnt the value of a timekeeper, actually, to give regular checks throughout the meeting. When we first started, the meeting took over an hour, and actually this was far too long, but with the introduction of a timekeeper, we were able to reduce that time down to about 30 minutes. This type of meeting really needs a really disciplined approach to attendance, and it was important to us that every area was represented. So we needed a real commitment to attend from everybody. So we ended up having to have an attendance list so that we could understand gaps and then go and help people to realise why it was important that they came. We needed to have an agenda, and in fact the agenda formed the basis of our PDCA cycles. Every time we checked and adjusted the meeting, we would update the agenda so that everybody knew where we were at. One of the things that we did find was that card decision-ready issues were really difficult for the ward teams to complete. It takes a lot of practice to do decision-ready issues, and often people would come to the meeting unprepared. So we would have to take about 5 minutes before the beginning of each meeting just to help people to write their issues down and have them on a post-it note. But we took the approach that actually it was better for us to take a coaching approach to that rather than put people off from bringing their issues to this forum. It was very important to us that we understood the issues that were happening on the wards. And when it came to discussing those issues, the value of a strong leader became apparent. It was really easy to talk endlessly about one issue without actually coming to any conclusions or assigning any actions to the issues. So a strong leader was very important. And we needed to ensure that every issue had a smart action attached to it with an owner and a timescale. And we made that everybody's responsibility. In fact, it became a bit of a joke in the meeting room that we needed to make sure that there was an owner to it. And it was important that we made sure it wasn't always the same owner. Our poor operations manager used to leave every meeting with a very long list of actions to take. So it is important where possible to spread the actions out amongst your team. And as for standing up, well, we found that nurses who spend most of their week on their feet appreciate being able to sit down, even if it's just for half an hour once a week. We had a real great success in understanding the problems faced by our ward managers and their teams. Issues such as hospital transport, pharmacy and cross-agency working were all brought to the Abeya, actions assigned and problems addressed. But we did find that sometimes an issue was too big to solve on the spot. And the power of this meeting is that you can collectively decide what those problems are. If a problem is just occurring at ward level, it can sometimes seem of little consequence, but when you can collate things in an Abea room, you're actually able to understand what an impact that has on your programme of work. As you can see from the chart, length of stay was one of these problems. It was the issue most frequently raised in the Abea, and for us this was a really positive outcome because we understood that despite the remit to reduce length of stay, I'm sorry Dave, but this wasn't happening at ward level, so the answer to your question is no, I'm afraid. So this was great because we were now able to ask ourselves why. We'd checked our plans, we'd looked at our target, we realised there was a gap, and now we were able to ask ourselves why. And this is a copy of my decision-ready issue that I took to the Abea. Because we realised that this was such a big problem for us, we knew that we needed to do a bit of a further investigation into what the problems were. And because we had the right people in the room, it was easy to gain that agreement that a further investigation needed to take place. And I think it's important to give you completeness of our story if I just take you through that for a few minutes and spend a bit of time telling you what we actually did. In order to understand root cause, you always need to go to where the work is, and for us that's the wards, and talk to the people that are doing the work. So this is a picture of one of our busy wards. As we investigated the current state on the ward, it became apparent that the Plan for Every Patient tool, which was supposed to help support our length of stay reduction, was not working properly on the wards. And the wards leads, they told us they were having problems with staff engagement and gaining enough momentum to utilise the tool properly. We did discover there were some practical problems, such as where we located the tool and integrating it into the ward routine. But one of our big concerns of the ward teams was that they were too busy to engage with the tool effectively. And we were a bit concerned by this because busy is a bit of a vague concept. We really needed to understand in detail what that actually meant. So this led us down the road of carrying out an activity analysis. Now, for those of you that haven't come across this before, this is where one person follows another person for a set period of time with their permission and notes down the detail of all the activities that they undertake in that period of time. This is a part of the template that we use, but there's lots of different templates out there. For the purpose of our study, we followed a nurse for 12 hours, 7 a.m. to 7 p.m, because this is when most of the decisions are made about patient care. And we were able to unpick some of the detail about what the nurses were busy doing on the ward. For example, they spent most of their time managing medicines, which you'd expect for nurses to do. But one of the very interesting elements of our study was when we actually looked at the interruptions that were happening to the nurses. Now, nurses are interrupted an awful lot during their shift. They're interrupted by other healthcare professionals like physiotherapists and doctors, and they're also interrupted by relatives and sometimes by clinical improvement facilitators. But actually, they spent an awful lot of time, 23% of their time being interrupted and dealing with the subsequent jobs from that interruption. And we calculated that a lot of these interruptions were asking questions about patient status, patient flow, what was happening next for the patient. These questions could have been answered if we were effectively using the Plan for Every Patient tool. So that for us was a very interesting aha moment. We spent a bit of time looking at the wards, but it was also very important for us to understand what the managers were doing as well. In our case, that's the matrons. These are the people that are supposed to be helping support the teams to implement Plan for Every Patient. But when we spoke to them, they told us that they were busy as well. So what were they busy doing? Were they busy doing the same sorts of things as the ward teams, or were they busy doing something else? So we needed to understand the content of their work as well. Now, our matrons are supposed to be operational. They're supposed to be out there trying to help the ward teams deliver the safety and quality agenda of the NHS. But when we did an activity study on them, we found that they spent 56% of their time in their offices, which was quite a lot of time, we felt. And when we looked in detail at what they were actually doing in their offices, we decided that we would carry out a diary exercise for them just to understand the content of their work. And we found that we'd actually given them and allocated to them 50 different sorts of tasks, so 50 different sorts of meetings or regular activities that they had to undertake. And in order to deliver those activities, they would have to work an extra 46 hours every month above their contracted hours. That's more than a week's worth of work, just to deliver the things that we'd put on their plate. That was without any extra improvement activities. So no wonder they weren't able to go and support the wards. So, what had we learned? We'd learned that nurses are busy. Without question, nurses want what's best for their patients. However, they've got multiple competing priorities. And because of that, it's really difficult for them to know where to put their energies. And their energies have to go into nursing their patients. So it's really difficult for them to devote any time at all to an improvement activity. And change is really hard on a busy ward where you've got 40 plus members of staff. We'd also found that our matrons were busy. And they have such a huge agenda, they weren't able to support the ward teams in a consistent manner. They weren't able to help them with their improvement activities. We did learn there were some practicalities which we could have quite easily solved, such as where we'd located this planning tool. But I think fundamentally what we'd learned was that we hadn't gone about implementing Plan for Every Patient in a controlled and scientific way. I'll explain that a little bit more detail. What we'd done, we have multiple sites, and we'd taken this fantastic idea and got very excited about it. Plan for Every Patient is a safety and quality tool, and it also gives us a length of stay reduction. And that's brilliant for us because that fits in with all of our agendas. So we'd put it in as many wards as possible across the site. We'd followed our exec team's remit in the first place of putting everything everywhere all at once. And then Plan for Every Patient had failed to deliver the length of stay reduction that we'd expected from it, and we knew that it was capable of delivering. And then we realised that actually we hadn't really followed our service improvement fundamentals. We hadn't followed PDCA, starting small, getting it right, fitting it into our routine before rolling it out to the organisation. So that was a big bit of learning for us. Okay. So, armed with our investigation, we're able to go back to the Abeya now with a better decision-ready issue. This is great because we've now done the investigation, we know what we want, and we're very clear on our recommendations. Because of the A3, we were actually able to say, what we want to do now is work with one ward. We want to understand how to fit it into the ward routine that already exists. We want to make sure that we engage the staff properly and that we can get the support that we need from the matron. And we want to make sure that we get the process right before expecting the wider team to do it as well. And because we had the right people in the room to make the decisions, of course it was accepted. And that meant that I was able to go and work with one ward. And I was actually asked to go and work with Jane's ward, who's going to come and speak to you soon. And we started to have discussions, and what it amounted to was a bit of a verbal contract between us. And that led to us deciding that we were going to attach the Plan for Every Patient planning tool, part of the checking of that tool, to hand over an activity that already pre-existed on the ward, that they were all used to doing. So it made a lot of sense to put the checking of the tool in there. We decided that we would make sure that we located the boards properly, near to where the work was, near to where the patients were, so the nurses didn't have too much walking backwards and forwards to utilise the tool. And Jane was very clever. She decided that she was going to make the use of it non-negotiable for her team. And that was a real turning point in managing this change. We decided on a 1-month trial, believing that this was sufficient time to prove the safety and quality benefits to patients, and also for us to gain a length of stay reduction. And we wanted to do that PDCA, that checking and adjusting and making sure. So we did this together regularly, making sure that it was working well for the wards. And there was also a little bit of bribery. Jane and her team have a mixed surgical specialty ward. They mix medical and surgical on the same unit, and nurses are happy to nurse both sorts of patients. However, because they had a lot of medical patients with long lengths of stay, they weren't getting their surgery through. And surgery requires a different skill set for nurses to look after those particular patients. And there were concerns that the nurses' skill set would be eroded. So we promised that if Jane was able to deliver a reduction in length of stay, free off some of the beds, that we would actually fill those beds with surgical patients instead. Okay, so to deliver a length of stay reduction, you don't need an obeyer. You need a practical methodology of how to implement that. And we've talked, both David and I have talked about Plan for Every Patient without really giving you an awful lot of detail about how it works. So we're very lucky to have brought Jane with us today, and she's going to talk you through actually how the Plan for Every Patient tool works and how she implemented it on her ward, and the benefits and the learning from her staff.